Hi, and welcome to the November 13, 2013 Plastic and Reconstructive Surgery Journal Club from St Vincent's Hospital in Sydney. I'm Damien Marici. This is Nick Hayden, who's one of the registrars of St Vincent's Hospital. As usual, we did 4 papers this month. The first paper was looking at the computer-assisted versus conventional free fibula technique for craniofacial reconstruction. And so, Nick, what was this paper about in a nutshell?
So this paper from Johns Hopkins was essentially looking at the use of computer design in pre-planning and manufacture of intra-op jigs as well as prevent plates and craniofacial models. Essentially it showed that it has a shorter ischemic time with all the osteotomies done in vivo as opposed to on the back table, but overall it didn't decrease the total operation time. As well, it didn't have a significant result on any post-op outcomes. They did talk about better cosmesis, especially for maxillary defects.
Yeah, there was a bit of discussion, some people saying that they don't do the osteotomies on a back table like Eduardo Rodriguez does, that they do their best to pre-plate the mandible before the lesion is removed and then attempt to do their osteotomies and even some plating down on the leg and then move the whole construct up and do the microsurgery. But certainly it's an interesting technique. There was one of the surgeons who's had a little bit of experience with it who was at the meeting who thought it was certainly interesting. I guess for straight defects it's probably not going to add too much, but for complicated defects, especially the maxilla, it probably has some advantages. Obviously you'd need to have the funding set up for it, have the time to the pre-planning which is involved.
There's also a very good point raised about, obviously the time taken pre-op planning, having the surgeon there as well as the cost of the software. Another useful point was often you can do a lot of pre-op planning, but usually the cutout is done by a separate team in a lot of units, and you're often left with a bigger or a different defect to what you first planned.
Yeah. Okay, but it was an interesting thing. Okay, that was the first one. Okay, the next 2 papers were on breast surgery. So the next paper was a matched cohort study of superior medial pedicle versus vertical scar breast reduction versus the traditional inferior pedicle wise pattern breast reduction. So what was this paper about?
So this is a retrospective review of a prospective maintained database. It was a matched cohort study with 50 patients in each group. It essentially was pro superior medial pedicle technique, and it was looking at post-op outcomes. It showed that there was no statistical difference between major and minor complications, and that the superior medial pedicle was useful in large breast reductions. The good things about this paper, it showed that with the vertical approach there's less tension, better healing, and there's also good functional and aesthetic outcomes for the superior medial pedicle.
Yeah. And they were getting quite large reductions, no matter whether it was with the superior medial pedicle, which has been one of the concerns of many surgeons. Actually, it's actually a concern of mine, that I find it difficult to get a larger reduction using a vertical scar superior medial pedicle as opposed to using a wise pattern superior medial pedicle. One of the interesting things is one of the consultants was saying they've never seen an inferior pedicle, which just shows there has been a paradigm shift in recent years, certainly in breast reduction performed in Sydney, where the vast majority of people have gone certainly to a superior medial pedicle, and many of us have also gone to a vertical scar sort of pattern. What other comments were there?
Well,
Hi, we're back again. Sorry, there was a technical problem there with the video recorder, but I think it's all sorted out now. So, Nick, you were saying?
So we were just finishing off talking about the cohort matched study, looking at the superior medial pedicle and the inferior pattern. It was an interesting discussion after the paper. Certainly not many of the consultants in the room had even seen an inferior pedicle, and there was some good debate about the benefits of the superior medial pedicle based breast reduction.
Okay, the next paper was by Tebbetts from Dallas, looking quantifying aesthetic and functional breast surgery nipple position, looking at vertical and horizontal skin excess for mastopexy and breast reduction planning. So what was this paper about in a nutshell?
So he essentially was trying to, design and give some objective parameters for pre-planning and post-operative results for breast reduction. He's got 124 mastopexy patients and 122 breast reduction patients that he's followed over 4.5 years. All cases were designed using the same algorithm that he sets out in the paper. It was reasonably interesting looking at some of his measurements, and he talks about the importance of the base width of the breast post-op. And he also shows that throughout the paper that it's very important to assess the post-op outcomes and use that to improve your pre-op markings.
So what he's doing in terms of determining the ideal position for the nipple areolar complex, the way most of us use is using it in relation to the inframammary crease. Other people have used it from the relationship from either the midpoint of the humerus or the sternal notch. I don't think too many people use those last two techniques anymore. Tebbetts was saying it's important to determine the position or the nipple areolar complex to IMF distance based on the base width of the breast, with a rough ratio being 2/3 of the width of the breast is the ideal nipple to IMF position. It was the first of 3 papers which will look at other factors of mastopexy and breast reduction design, and I think it was sort of a good starting point talking about the importance of a measurement that many of us don't currently consider when designing our mastopexy or breast reduction incisions. All right, the last one was the percutaneous aponeurotomy and lipofilling, or PALF, which is a regenerative alternative to flap reconstruction by Roger Currie et al., international cast, published in a very recent PRS. So, Nick, what basically was Dr. Currie talking about?
He was essentially combining 2 techniques, lipofilling and then percutaneous aponeurotomies, as a minimally invasive alternative to flap recon. In this paper, they review 31 patients who underwent this procedure for a variety of conditions, mainly breast as well as extremity contour defects. Essentially, the surgical technique is to inject lipoaspirate to increase the tissue turgor, put the fascia or scar tissue under tension, and then release that with an 18-gauge hypodermic needle in a 3D sort of matrix pattern, which then creates a regenerative bed for the fat to graft into. There were some subjective improvements in the 5 cases that were presented, and they give some good evidence for its use in contour defects as well as in breast cases. It's an interesting and very novel technique, and it promoted quite a bit of discussion in the room.
Yeah, this is something really new that obviously none of us have tried ourselves, where you're actually putting fat into the tissue first, putting it under tension, and then making these little micro perforations in the underlying fascia so that everything sort of stretches out just like a meshed split skin graft. It is interesting. I couldn't actually think off the top of my head of any of my patients who may have benefited from this technique, but certainly it's essentially scarless surgery, and some of his reconstructive cases which he presented were very impressive. The scar release following one patient with axillary scarring, another one who basically had a full breast reconstruction using this technique, and with no scars elsewhere on the body. It's a very interesting technique. It'll be interesting to see where it is used, or if it is used by surgeons here and around the world. Okay, well, that's it for another Plastic Surgery Journal Club. For those of you who were there, I hope you enjoyed it. And for those of you watching now, thank you for listening. Bye.
Thank you. Bye.